After a long session on day 1, we are coming to day 2, which will be divided into plenary lectures and workstations. So today the first talk will be by Dr. Avinash Ignatius on infection outbreaks in dialysis. We know that however we take care of infections and endotoxins, there will be some outbreaks somewhere in our unit. Not now, but maybe 1 month or 2 months down the line, somewhere it is going to happen. So how to identify these outbreaks, how to tackle them, and more importantly, how to prevent them. So I call upon stage Dr. Avinash.
Let me open the session by just welcoming you all on this beautiful Sunday morning. It's been unusually cool today outside compared to what the summer has been last couple of weeks. And I'm glad all of you are here for today's talk. So, infection outbreaks in dialysis unit. Now, it's quite a large topic. I have tried to keep it simple and more of a practical discussion rather than too much of theory. So outbreak is basically a sudden occurrence of something unwelcome. So we don't have an outbreak of happiness or an outbreak of something positive, something bad. We have an outbreak of war now with Russia and Ukraine, and similarly outbreak of disease. Outbreak of infection is usually defined as maybe 2 or more linked cases of same illness in a situation where the observed number of cases are in excess of what exceeds the expected number. In some situations, a single case of disease may be also considered significant or an outbreak. You can see that 2 years back or 2.5 years back when the pandemic started, it was a chaos when even a single case was detected in our dialysis units and it was considered like outbreak. And for the first 1 or 2 weeks, they were almost shutting down units completely with a single case in the unit. Things have changed over time and the scenario has changed, so now we wouldn't consider a single case of COVID-19 as an outbreak in our units. So things change with time, outbreak definition changes with time, but probably COVID-19 is more of an exception and an outlier than what we routinely see in our day-to-day practice. So when we think of outbreak, if we are fond of reading or movies, we will remember Robin Hood's novel in our medical days, and it was one of, at some time, the New York bestseller list. Subsequently, a movie came on that. So there's a lot of glamour around outbreak. But then that nightmare turned into reality again in the last 2 years. But when we don't have sufficient data or information, the actions or the reactions to that can be sometimes unscientific, like what we see here, spraying the walkways with disinfectant may not have been the most ideal things required at the time, but has very good optics. So outbreaks for us are not so glamorous, not so obvious. They are all lurking in the shadows, and many times by the time we see the outbreaks or we get to know the outbreaks, it may be quite some time since it has passed, and the number of people who get affected by the outbreak will be much higher than we actually know. And there are a lot of studies or outbreaks reported in the literature, or if you look at the USRDS data, there are outbreaks reported, but probably they are again a minute number as compared to the number of outbreaks which actually happen in our units. In India, probably it's even less what we know about the outbreaks, except what probably happen in our own units. So outbreaks can be non-infectious and they can be infectious outbreaks. And just to go ahead, since my talk is infectious outbreak, I'll just quickly go across non-infectious outbreaks. And if we look at it, non-infectious outbreaks like an outbreak of hemolysis, this was because of a batch of dialyzing in the lumen had got narrowed, and because of that there was excess hemolysis in a setting. Fluoride intoxication from a deionization plant, hemolysis due to chloramine exposure due to RO issues. Dialyzer membranes also. So an outbreak happened because there were dialyzers which were not used for a long time. So normally when we stop equipment, what goes in should go out first, but these were not routine practice, and when the storages are not very well planned, some dialyzers remained behind, and after 6-7 years those dialyzers were used, and then the patients had reaction which were degenerative. So what happened with that membranes is that because of that, expiry dates were put on dialyzers. Others prior to 1996, dialyzers did not have an expiry date. So that incident led to this change. Then aluminum intoxication from a pump. Then a more recent one, which all of us would probably recollect, is heparin with oversulfated chondroitin sulfate. So we can have a complete talk on non-infectious outbreaks, and it can be a completely different topic. So going ahead, infectious outbreaks, most would be either bacterial, viral, or fungal. So one way to classify is in that, but if we go in our clinical practice, it would be more practical to go for symptomatic outbreaks and asymptomatic outbreaks. So our dialysis patients are particularly at risk for infection. Now, they have a weakened immune system. Their frequent access to the bloodstream during dialysis, during blood investigations, they have more frequent hospitalizations and surgical procedures for various reasons. So for infections to happen, we need a susceptible host. So the host should be a person at risk. So here it's the dialysis patient who is at risk. There should be a source of germs, and there should be a way from this source the germs can move to a host. Now, dialysis, a patient is coming for 4 hours. There's not enough time for the germs to move from one place to another. It's always some source which may take the virus. Now, the source may be another patient, the source may be another healthcare service provider, the source may be anything else which comes in contact with the patient, like the dialysis water, whatever equipment is used. Any of these can be a source of infection for the patient. Even the environment or the air we breathe can be a source. So some of the factors which are related to infections or infectious outbreaks. So there are host-related factors in which most importantly impaired host immunity, coexisting comorbidities like diabetes, cardiovascular, coexisting other chronic infections, poor personal hygiene habits, type of dressing used, and then some people may have colonization with staph aureus, age, presence of diabetes, especially if it is uncontrolled. Especially we know the challenges with controlling diabetes for CKD patients, and a lot of times we have to keep higher targets of glycemic control for these patients because of hypoglycemic events. Iron has been found to be associated with increased risk of infections. So overuse of iron also should be watched, that because a lot of times we do practice using IV iron as a routine without monitoring for whatever cost and issues, but maybe in between once in a while we should keep a watch on the iron levels. Pathogen related biofilm formation in chronic catheters, virulence of bacteria, presence of infection in the resistance to antibiotic therapies. Catheter related factors, again, whether it's a temporary or cuffed catheter, the site of insertion, femoral, jugular, subclavian. Although subclavian is considered to be the least infectious, but because of stenosis, we don't recommend subclavian catheter as a site for dialysis access. Previous history of bacteria is a strong risk factor for repeated infections. Colonization of catheter tip, hematogenous seeding of catheter can occur from other sites of infection in the body. Contamination of the lumen by injections or drugs which are used. Inadequate infection control practices, improper aseptic techniques, incorrect use of disinfectants, antiseptics, another reason for that. Poor water treatment, poor maintenance of RO systems, dialyzing reuse being done improperly. So all of these factors are contributing to infectious outbreaks. So looking at this, the number of places where each of us need to keep a watch is humongous, and it is likely that we will, or even somebody else will, miss points where infection or these outbreaks can happen because of missed corrective measures. This is just to highlight the number of places where infection can enter into a dialysis patient. So if we look at there is an infusion line. Now, most of the good centers, there will be a different infusion line for saline, but many small centers or peripheral centers where non-trained technicians are there who are not, the same IV line and the bottle remains because there is some saline left in that, next patient comes and the same thing is connected. So the blood which has entered the IV line again contaminates. Then we have this bubble chamber. So sometimes the air is aspirated. During air aspiration, that the syringe gets contaminated. The syringe is kept aside and the same syringe is used in the next patient, believing that that is not contaminated. Then we have transducers, pressure transducers. So a lot of centers or smaller centers or which are not under care of nephrologists or their transfusion protectors are not used. Directly the tubings are connected, the blood enters the sensors will become different, that's a different matter, but the blood which comes back again in the next patient, that can again add to infection. Surface of the dialysis machine, where a lot of touch happens between the patient, the access of the patient, and again back to the screen. And if inadequate cleaning of this would again lead to cross-contamination infection for subsequent patients. Blood pressure cuffs, then injection ports, the access points itself, if they're not properly disinfected, the surfaces, the armrests, the tables. So a number of places and sources for infection, the water system. So all of these are possible sources from where a dialysis patient can get infection. So if you look at symptomatic infections, most of the symptomatic infections are bacterial. Typically patient may have fever, may have chills, rigors, sometimes unexplained hypotension during dialysis. Deterioration of general health, none of the other symptoms are, especially elderly or diabetic patients, they may just show gradual deterioration in their overall health, unexplained hypoglycemic episodes happening. So these are more frequent with temporary catheters and tunnel catheters. The most important things which you will see is the timing of the symptoms. Most of the time these patients will be okay when they come to dialysis, but when the dialysis started, within half an hour or 1 hour they start developing symptoms which get worse with time. And once dialysis gets over, they receive some or the other therapy like some kind of antihistaminic or steroid during the dialysis, thinking as an allergic reaction. And a lot of times, since dialysis units and centers are away, and nephrologist is not practically going to be present all the time, automatically this is like a reflex action when a person has chills and rigors, that is given. The next session again that is given. Finally the patient, when he is too unwell, he reaches a nephrologist or a more experienced technician probably would tell the patient or call that this is happening. So by that time a lot of time is lost and a patient suffers. So not only catheters, although they are the most common, AV fistulas get infected, AV grafts get infected, and they can have severe problems for patients. And we have to be particularly careful for AV fistula and graft because they are the most important lifeline for patients. And if you lose a fistula, putting another access is again predisposing him for repeated infections. So these bloodstream infections with vascular access, especially with catheters, it has around 12 to 25% mortality. So it's not a very benign thing. Almost 1/4 or 1/5 of the patients will die because of these infections. If they survive or if the infection is cured, there is a very high chance that these will recur. And many of them will develop metastatic complications, especially if the infection has been there for couple of weeks and it's not been treated, just being given symptomatic care. They can develop infective endocarditis, osteomyelitis, septic arthritis, pulmonary embolism, which then require longer antibiotic therapy, sometimes catheter removal, a lot of expense on the side of the patient. So most commonly the organisms which are from these such bacterial infections are usually from skin contamination. 80 to 90% are staphylococci, aureus or epidermis. 10 to 20% isolates can be gram-negative bacilli, and these usually are again touch contaminants from either the patient or the technician. And all these discussions which I have had are basically indicators of some breach in standard asepsis protocols. If the standard asepsis protocols are followed 100%, is very, very less likelihood of any patient having such infections. So dialysis water as a reservoir. Now it's relatively less frequent because and it has probably reduced over time because the quality of RO and maintenance has improved. The maintenance has improved, but still it can be missed because we don't look at dialysis water as a source of bacterial contamination so frequently. The dialyzer membrane acts as a barrier and it kind of gives us a little sense of safety that RO water is not going to cause infection to the patient. There are some studies which have also suggested in which they showed the normal level of endotoxins or even up to 2 to 3 times of endotoxin levels in RO water does not significantly cross the dialysis membrane barrier and less likely with bacteria. But however, certain RO systems which are, those studies are based on really medical RO systems, but in India, in our practice, many places we have RO systems which are probably industrial grade RO systems. The maintenance is not the same. The investigations and regular checkups are not the same. So we might have endotoxins levels which are much higher and bacterial colonization much higher than what we look at in the Western setup. The culprit sites in the water plant would be the treatment plant, the RO membrane. It could be the distribution system, or it could be the water system in the dialysis machines itself. So usually lapses in disinfection, maintenance and monitoring will lead to this kind of a problem and dialysis water becoming a reservoir. And these reservoirs, the pipes become places where we have biofilms develop for gram-negative bacilli, non-tubercular rapid-growing mycobacteria develop, and these are very difficult to eradicate over time unless specific managements are done. Some of the waterborne pathogens which have been isolated in some of the outbreaks are Proteus mirabilis, Stenotrophomonas maltophilia, Candida, Ralstonia picaria. These are organisms, if we see in some patient, we should start thinking that probably this is the source of it, probably is the water system and not from a patient to patient or a healthcare worker to patient infection. So other environmental sources which may not come first to our mind are the priming buckets. So priming buckets are usually kept at the side at the bottom of the dialysis machine and basically are there for the saline which is being used by priming to drain into that. Now that priming bucket also drains blood at the end of dialysis when the dialysis ends. Subsequently, the next dialysis, if it comes and the person again his tubings are dipped into that, if it comes in contact with the bucket wall or the fluid inside, or if the buckets are not been disinfected for some time, there is a chance of bacterial overgrowth or fungal overgrowth, and these can also lead to outbreaks in dialysis units. And one of a recent report where they found Candida tropicalis outbreak in about 7 to 8 patients were found to be the contamination of priming buckets, and the buckets were not being disinfected adequately in those units. Then contaminated sinks, not having separate sinks for hand wash, and for dialyzer reprocessing. Defects in dialyzer reprocessing where adequate disinfectants are not instilled or the concentration of the disinfection not adequate. Air conditioning systems can be a source for outbreaks, especially if the air conditioning maintenance has not happened for a long time, or if there has been some construction going on in centralized air conditioning systems, there are chances of fungal and spores and infections outbreak happening in a unit. So these are some published reports in the last few years where they found different organisms in dialysis water as a reservoir. So you have Candida tropicalis with saline prime buckets, and it was found in RO water, it was found drains, wall boxes, it was found. There was mycobacterium in incoming supply of the city water. This was actually for a home hemodialysis patient. Then streptococcus in dialysis water, again contamination of municipal water, sink and water used for hand washing, dialysis drains and sinks. And even sterile water was at some stage found to be contaminated with even treated RO water. So a lot of sites in the water system where we could be a source for infectious outbreaks. So we need to keep our antennas open. So just a small chart where if an HD patient presents with fever and so if there is an evidence of any localized infection, then it's easy, we go for that infection and treat it accordingly. If there is no evidence of localized infection but the infection is life-threatening, the patient is having severe symptoms, patient is in shock, then we need to give empirical antibiotics. Now it can be vancomycin, gentamicin, or vancomycin or the third generation cephalosporin. If the infection is not life-threatening, there is a central venous catheter in that patient. If there is the central venous catheter, use vancomycin and gentamicin or vancomycin and third generation cephalosporin. In the absence of central venous catheter, if there is a high incidence of MRSA, then we need to go for vancomycin and gentamicin or a third generation cephalosporin. But if MRSA is not significant, then cefazolin and gentamicin should be considered as the first line antibiotics and preserve vancomycin. So the challenge with dialysis patients when they have an infectious outbreak is giving antibiotics. a lot of them have already poor veins, we try to avoid giving IV punctures for them. So choice of antibiotics ideally should be such that which can be given on dialysis sessions with a gap in between. So some of the easier to use are vancomycin, gentamicin, ceftazidime, cefazolin, and even daptomycin. So all these antibiotics have an advantage that in these doses we can give them on dialysis days and avoid having to have a separate IV line and IV pricks on other days. So antibiotic locks is a controversial point where there has been a lot of debate, and probably still the jury is out whether antibiotic lock solutions should be used, should not be used. But one place where probably antibiotic lock solution can be useful is when a patient has a very precious access. He has had multiple access earlier, there is no alternative access available. Patient has a severe infection. Normally with staph aureus or Pseudomonas, we would want to take the catheter out, but if we don't have a choice in that situation, or we want to salvage a catheter, so during salvage, probably definitely with systemic antibiotics, we can use antibiotic lock solutions and consider using that. So sometimes it might help salvage a catheter at least for some time. So vancomycin, ceftazidime with heparin, vancomycin with heparin, ceftazidime with heparin, or cefazolin with heparin are different combinations which are suggested for antibiotic locks. In routine practice, to give antibiotic locks is not recommended, it's not part of the routine guidelines, because there is a strong fear of developing antibiotic resistant bugs and then difficult to treat infections. However, there are some studies which have shown that the antibiotic dosages in these antibiotic lock solutions, the concentration are so high that infections don't develop, and there are certain studies for 3 years, 5 years which have shown that they have not seen any increased incidence of antibiotic resistance. So it is still a grey area, it's not clear, so probably wherever we can, we should avoid antibiotic lock solutions, whereas and really judiciously choose if we want to give that or not. So when do we recognize an outbreak? So when a cluster of patients develop similar symptoms in a short period of time, so that short period of time can be different. It could be one session of dialysis, it could be within a week of dialysis, because the incubation period will be different at different times and where the infection has been acquired. So to investigate an outbreak, looking at all the sources from where infection comes, we need to be really like Sherlock Holmes and have a really high index of suspicion. Always think that there has been a break in asepsis and protocol, and really go behind to find if there is a possible break in our system where something has happened, because that's the most important to prevent. Even if it's a single case, we need to look at where there has been a possible breach, because this could be the sentinel case and we may get more cases in the coming days, but if we lose that time, we might cause more spread of the outbreak. Now, when we start seeing what a person has an access related infection or a bloodstream infection, we look at the access which the patient has, whether he has got a tunnel catheter, what has happened to the exit site, is there evidence of infection there, assess the patient for any other focus of infection. Now, the standard recommendation is to send 2 blood cultures, one from the catheter and one from the peripheral line. Now, there can be a little problem with this recommendation for dialysis patients, because again, sometimes to get a second blood culture from peripheral line can be difficult. So some have suggested either take 2 cultures from the 2 lines, both arterial and venous, and some have suggested to take a blood sample from the tubing if there is no other obvious place to take a culture. Once we have multiple patients who are having or presenting with similar features, we may get cultures, we may not get cultures which are positive. If we get cultures which are positive and show the same organism and culture pattern, we know that this is the same infection which is there in multiple patients and probably there is a common source. Or if it's a rare organism and it is there in multiple patients, again it suggests that there is a common source for this. So collate as much data as possible, the days these patients have got dialyzed, shifts which these patients have got dialyzed, the machines which they have been on, the station, the staff, and the reuse. Now, this information can be only got if it has been recorded earlier. And unless this is a routine part of recording everyday information in the dialysis records, it is not going to be easy to get this once a person has presented with infection and going backwards. So it has to be a part of prevention of infection control that the data should be collected on a regular basis. Look at the history, the duration of access of the patient. The longer the duration, more likely chances of infection. Did those patients get outside HD somewhere? Were they admitted in the hospital for any other reason or procedure? Now, they can acquire infection because of contamination within the hospital itself. A lot of times, however much we like that the dialysis access should not be used for IV infusion and injections, but never, having said that, every time there will be someone who has opened the dialysis access and used it for an infusion and injection, not locked it properly or left the cap open. These are some issues when the patients get admitted. So many times patient comes back after an admission and then they present with catheter-related issues. Staff interview is very important to go back and see if there has been any issues in the way the dialysis has been done. Many times if you go back, you find out that on that day there were 3 persons were on leave, and instead of 7 people, there were only 4 patients managing the dialysis unit. You realize, and it is one of the strong factors of infection spread when the staffing is disproportionate to the number of patients. So these small things increase the risk of infection. So there might be a shortage of some material, maybe shortage of gauze. They may have actually got material which has not been adequately sterilized, or they sterilized but it's not appropriately sterilized. So you find out that the gauze was still damp, which was opened from the packages for cleaning the fistula or disinfecting the access sites. Past infections, and look for any other possible sites in the patient which could be a source of infection gone and then infected the catheters. Labs, blood cultures, definitely. So this we have discussed in the previous, the antibiotics blocks restricted only in case of repeated ARPs, access-related bacteremia despite universal precautions. So preventing bacterial infections, the most important cause of bacterial infection in patients is the access and absence of fistula. Having a tunnel or a tube catheter is one of the highest risk factors of having a bacterial infection. So early creation of fistula, prevention starts even before the patient goes to dialysis. Early creation of fistula and fistula first is what we need to follow and try to convey to the patients that they need a fistula before. So some of the best people to convince a patient is a dialysis patient who already has a fistula, has gone through the procedure, is the one who can actually, best person to convince. They will not listen to the doctor as much as they listen to a patient who has already undergone that. Second is a very important step but missed step when patients come to a dialysis unit is washing their arms before getting onto the station. A lot of times there is grime, they have traveled in the heat and dust, there is a lot of dust and sweat, everything on the hands, and when the grime is not cleared, our disinfectants will not be as effective as it would be on a clean hand. So washing arms before getting onto the dialysis station with the soap and water is a simple process which can reduce the infections of our AV fistulas or grafts. And having a dedicated washing area when the patient arrives in a convenient area is one of the most important things. If that is not possible, we can even tell the patient that before traveling you wash your hand with soap and water at home and put a full sleeve and then come to the hospital. So that may also help reduce the chances of infection. Strict adherence to CDC guidelines for connection and disconnections, which I will talk on a separate slide because it is common for all kinds of infections. Exit sites care for catheter-related infections. So antimicrobial ointments such as povidone iodine and mupirocin ointments on a regular basis has shown to reduce the bloodstream infection by almost 75 to 90%. There are chlorhexidine gauze available which can again reduce the chance of infection. Newer hubcaps are available which have got a kind of a projection or a stick at it which is in chlorhexidine, so that enters the hub of the catheter and the cap is applied. Using alternative lock solutions like antimicrobial lock solution in which citrate has shown to inhibit biofilm formation, whereas heparin is shown to promote biofilm formation. So citrate might be a better option as compared to heparin. Ethanol and toluidine are newer suggestions. Now ethanol has shown to have good efficacy, but the problem with ethanol, which has to be used at least 70%, is degrading the catheter material, the joints, which can be an issue. So we'll have to see which catheters are compatible, so that creates that's a little drawback with using ethanol. Now, intranasal mupirocin primarily is against Staph aureus colonization in the nose. Now, there are 3 different ways people suggest. There are no exact guidelines on which way to go. Some say screen the patients. If they are positive, give intranasal mupirocin. Another guideline says that suggestion is that to use mupirocin for all patients because it's generally more cost effective rather than trying to test and find out, give mupirocin to all. And some suggest instead of using mupirocin routinely and having a possibility of infection, only give those who actually have an infection. So from the RO or the water as a source for outbreaks, having a well-designed RO from the beginning is one of the most important aspects. Unfortunately, a lot of times the location of the RO and the dialysis unit can be a distance, and the distance which the pipe has to travel, the number of bends and joints which the RO system needs can be much more than desirable, and each joint and bend adds to the chances of biofilm formation, colonization in the RO system. A regular maintenance of the RO is very important. Disinfection of RO lines on a regular basis, prompt repair of any leakages, and these leakages are not just in case of the RO water leaking out, but also when disinfection is done, the disinfectant would not remain in the RO, or the disinfectant would not remain in the RO lines as long as required because of leakages, and effective decontamination will not happen. Dialyzer reprocessing has to be carefully watched because it is one place where the blood is going to directly enter the dialyzer, and if there is improper dialyzer reprocessing, then the risk of infections can go up. Machine disinfection on a regular basis, daily disinfection between sessions, and thorough disinfection and the night between 2 days is important. So viral infections, usually they are the important ones which we are really going to discuss about are bloodborne, HBsAg, HCV, HIV. Now, HIV dialysis has gradually started picking up, but is still not very commonly seen in most of the units. Usually, hepatitis B and hepatitis C are both asymptomatic and incidentally detected. Very rarely in our units they present as acute hepatitis. Other viral infections, airborne, are influenza, COVID-19, bacterial infection, pneumonia, H influenza are there, but I am not going to focus on those for the limited time. So hepatitis B patients have a standard recommendation for keeping them isolated. There are differences. One is hepatitis B is a DNA virus. It has up to 10 times more infections than a hepatitis C virus. It is more likely to spread with both blood and body fluid splashes. Fortunately, vaccination is available for hepatitis B. Chronicity is less, and there is a standard isolation requirement for hemodialysis for hepatitis B patients. So chances of hepatitis B infections are very low in most units at present because hepatitis B vaccination has really increased in the last decade, not just in dialysis units but also around in the common public. And keeping a standard isolated HD station which is isolated has made with no reuse protocols has reduced hepatitis B cross transmission significantly. Now, HCV does not have a vaccine, unfortunately, and chronicity is common. Isolation is not standard recommendation because it has been found, despite all precautions, hepatitis C has been found to be transmitted through various modes if standard infection protocols are not maintained. So, long-term consequences of hepatitis C is increased morbidity, mortality. Almost 30% patients may show cryoglobulinemia, there is cirrhosis, and a significant number of hepatitis C related cirrhosis patients can develop hepatocellular carcinoma. So transmission of hepatitis C is primarily from contaminated surfaces which are contaminated with blood, instruments, objects which have been shared between patients, equipments, supplies, healthcare workers through their gloves or hands, and all of these happen only when there are breach of protocols or the standard protocols which are recommended for preventing infections. So some of the factors which are associated with higher chances of viral infections are one are small or cluttered treatment areas. So many times we'll see dialysis units are probably the most crowded and cramped up places. Somehow they are neglected, so for as many machines or as possible can be cramped up in a space, limited space, that much dialysis machines are put, which leads to a lot of clutter and no space for adequate separation of infected, non-infected material. There is inadequate separation between dialysis stations, so the same tray may be here for the next patient and for the one on this bed, and infection may transmit. Pressures for quick turnovers between shifts, which even though the shift planning may be good, but a lot of time patient comes late, he wants his 4 hours, the next patient is waiting outside, he wants to get in quickly. Some patients can be very aggressive, and the technicians under pressure would probably sometimes take patients without adequate disinfection. So rushed treatment schedules, then high staff turnover rates. Our dialysis technicians frequently change, new staff join, they are not aware of the protocols, younger staff who have not yet had adequate training. Staff lacking infection control training and lack of training and supervision. So again, detecting an outbreak becomes much tougher in blood-borne viral infections because usually they are asymptomatic. So the standard recommendation for dialysis patients is to do a monthly ALT and suspect if there is a rising trend, even though the range may be the normal. Regular screening should be done with third generation tests for hepatitis C, and which should be done 3 to 6 monthly intervals. A lot of places do card tests which are notorious to be false negative in dialysis patients and should be ignored completely. There is no use of doing card tests in dialysis patients for hepatitis C. Keep a high index of suspicion when there are new transfers from other units, patients return from holiday dialysis, patients who have been dialyzed in proximity to known HCV patients, and whenever there is an anti-HCV positive, do confirm it with a nucleic acid test. So prevention will cover different aspects. Wherever blood contamination can happen, that can contaminate the next person. So there is management of the equipment, there is management of the waste which is produced, preparation practices for injections, the heparin, whatever additional injections are to be given to the patient, hand hygiene and gloves change between patients, between sessions, and screening for anti-HCV antibody. So patient education becomes the most important. They should be aware that what is being done and what precautions have to be taken. If the patient is aware, he will point out to the technician when they have not done hand washing or they have not complied with gloves change. Their compliance to other treatments are important to prevent infections such as their diabetic medications, their regular treatments. Vaccination follow through, make sure that the patients are counseled, explained repeatedly, ensure that their hepatitis B vaccinations are up to date. Preventing additional infections like COVID-19 vaccinations, flu vaccinations and pneumococcal vaccinations should be up to date for these patients. Allow adequate cleaning between station. The most important point is when we put a disinfectant on the machine, that should be allowed to dry. Allowing to dry is a point which a lot of time is forgotten because effective disinfection will happen only when the disinfectant is left long enough to dry. We need to change transducer protectors between patients, change gloves between patients, and separate sinks for dialyzer and reprocessing. There are times when if there is very high venous pressure or if the pressure in tubings goes very high, the transducer protectors, the membrane may rupture and the blood may contaminate the pressure sensors. So in those situations, ideally the machine has to be taken out of service, it has to be opened and checked if there is any blood contamination inside, cleaned, and only then brought back into service. So scrub the hub protocol, which has been repeatedly highlighted, and CDC recommends repeated training and retraining on this. Perform these steps have to be followed every time before a catheter is accessed. Perform hand hygiene and don new gloves. The catheter has to be clamped before opening the caps. When the catheter is clamped, remove the clamp. Take a new antiseptic pad for each hub. Scrub the sides and thoroughly the scrubs have to clean the threads on the hub. Remove any residue such as blood or any dried material on it. Using the same antiseptic pad on that limb of the catheter, few centimeters below the hub, the tubing should be cleaned. Repeat the same thing for the other hub, and only then this should be capped with a tubing and the connectors. None of the hubs, once they have been disinfected, should touch any unsterile surface. So a lot of times we keep a sterile sheet underneath, and once the hub has been cleaned with sterile material, it is placed on those so that there is no other contamination of those hubs. So these have to be repeated in case there is any disconnection for any reason that the system is put into circulation, or if the patient goes out of the bed for any reason, he goes to the washroom. These steps have to be repeated whenever a disconnection and reconnection is done. For injectable medicines, we should avoid medications and blood specimens in the same place. The area should be designated where medicines are prepared, heparin is prepared. Multi-dose heparin vials should not be used between patients. If there are multi-dose vials, they have to be loaded into syringes in a separate medication preparation place, and those syringes have to be carried to the patient's bedside. Avoid mobile carts to deliver medicines because there is a high chance of contamination being transmitted through these. And deliver material for each patient separately. A common trolley should not deliver for multiple patients. So waste management, tubings and dialyzers should be appropriately cleaned. The tubing should be bagged and discarded. So bagging should be done at the bedside, and not the tubing should not be carried with dripping waste all the way across the dialysis unit to the waste area. They can either be bagged and then put into the priming buckets and taken with the priming buckets to prevent spread of infection. All consumables brought to that particular station should be discarded before disinfection. Even material which is unused should not be taken back to the clean area and then used for other patients. So every patient's the minimum material required should be picked and brought to that station, used, unused, that should be discarded away once the person is over. Only after all consumables have been removed should the surface disinfection of the machine started, and not before that. Staff needs to be vaccinated. Infection control training at joining and at a regular basis should be reinforced at least every 3 to 6 months. There should be a regular audit, maybe by another team person or the staff, or by a third person who comes and observes and audits their infection control practices. So if there is a specifically HCV related outbreak, one is we need to review the records, look at the patient's previous HCV reports, look at the enzyme levels when they have started rising. A lot of times the HCV report may come positive now, but we may see that 3 months before there was a uptrend in his AST/ALT levels. Compare the station assignments, staff assignments, the machine and shift. Review again the audit of infection control practices. In case an outbreak has happened, then the frequency of HCV testing has to be increased and is recommended to be done monthly, at least for 6 months since the last detected case. So these are some checklists which I have put here. These are the last few final slides. These are from the CDC guidelines. So these are useful and can be downloaded from any of the units which require. So checklist for hemodialysis, catheter connection and disconnection. So simple checklist which a technician can look and tick mark. So wearing of mask, perform hand hygiene, put on new clean gloves, clamp the catheter, then remove caps, scrub the catheter hub, allow it to dry, connect catheter to blood lines aseptically, remove gloves and perform hand hygiene. So similarly for a disconnection, the checklist is here. These are audit tools when we have another person observing someone who is doing, and they have to check and if every step has been taken or not, and subsequently an audit of this will help in training purposes for the team. So similarly for a checklist for a disinfection for a dialysis station, about each step in its sequence. So this will again help the team to do the process in an appropriate way. And again an audit tool to see that these things are being followed and subsequently follow up on that. So dialysis patients are prone to infections. There is a high morbidity, mortality associated with infections, either bacterial or viral. It is financially debilitating. It is important to reinforce vaccination for both patients and staff. Strict compliance with standard protocols for infection control are essential, and a regular training and audit, without which the infection control protocols may not be sustained. So this is what we need. So this is my last slide, and I think we can
take one or two comments or questions. Yes, I want space to ask questions.
Not consultants.
What he meant was he didn't want consultants to ask questions. No, because actually Avinash helped us a lot. In our hospital we had an outbreak of hepatitis C. So I had called him, this was about maybe 10 years back. So ever since that was a lot of help. My question to you was a little bit more specific. What solution do you use to clean the perm cap? You know why I'm asking you this question? Because I have found that if I have no concrete evidence, because I have switched over from spirit to betadine, because of spirit, I don't know whether it happens with that hemosplit or with the palindrome, but they tend to get sort of kinked and now I thought it was the heat that is causing this, but why should it happen? I mean, it's all covered catheter and there's no heating device which is kept over there. But this is one common observation I have seen, and the life of the catheter then gets reduced. Any comments on that?
It's true, sir. Alcohol interacts with some of the materials which the catheters are made, and they may affect even the joint or the material of the catheter in the long run. So strong alcohol solutions have a little drawback on that. So we use iodine for our own, in our own unit. Spirit is used for the and when there are the antiseptics which are suggested are basically intermediately strong antiseptic. We should not use mild disinfectants. And in that, 3 of the ones which are recommended are either iodine, then 70% alcohol, or 0.5% chlorhexidine with alcohol. So out of these two, if you're using chlorhexidine, one point which I want to remind is that the catheters on the surface should be cleared of any debris or dry material or grime which is there before using it, because otherwise it's not as effective. Whereas iodine and alcohol would be effective in that. But as Sir said, I think ethanol strong has been an issue with the material in which the catheter is interacts, and
chlorhexidine also for silicone catheters, chlorhexidine is not recommended by the CDC. They say betadine.
Yeah, betadine is the best. And even we used the ethanol lock in 2 of our patients, almost around 10%. They had damage to the catheter and we need to change it. But we were able to clear the bacteria, even bacterial biofilm was clear when we use ethanol lock, especially when you have a 2 vascular access failures. So we are using it. The clearance of the bacteria is much better rather than using the antibiotic alone.
You spoke about HCV testing, the card test and so even ELISA is not very great test in dialysis patients. So what we have switched it to NAT testing. We have blood bank which is giving NAT tested blood, and most of the hospital based units will be backed up by blood bank. So you can ask your blood bank person whether they are doing NAT test, and NAT test is not expensive compared to ELISA. It's not in our hospital it takes about 1,000 for ELISA and 1,200 for NAT. That 200 rupees may not matter for dialysis patients.
Just expand the NAT for this.
Yes, NAT is nucleic acid amplification. So it gives only positive, it gives a qualitative result. Then we have to investigate which one it is.
But though it's qualitative, its least count is lower than that of a quantitative
Yes,
PCR.
yes.
It gets even 3 copies of HCV RNA.
There was 50 copies in
In a PCR is 40 and the NAT detects 3 copies.
And it's done by all blood.
I had an outbreak of hepatitis C many years back, about 10 years back. And we reviewed all the protocols and we wrote a paper on use of FMEA to control hepatitis C infection, and it was published in the International Journal of Quality and Management. So one thing which we changed was we were using separate sinks for hepatitis C positive patients and negative patients, presuming that all the negative patients will always remain negative. That was a false presumption. So then we started using sodium hypochlorite clean disinfection of the sink after every dialyzer is washed. Who knows who is going to get converted at what time?
So your sinks were porcelain.
No, they're stainless steel.
So then hypochlorite on stainless steel will bear
Steel.
Yeah, it
Steel.
was heater holder.
But then I have not changed. This may be theoretically right, but I have not changed my sinks for about 5 or 7 years.
delegates if they have any questions.
So meanwhile, we had an outbreak of probably around 8 or 9 years back it was a very short and a very intense outbreak. Like it didn't require much to know that something is wrong. Morning shift patients came and about 3 patients developed severe chills and rigors during dialysis within the first hour or so. And it was something which had come out of the blue because we had not seen any incident happening in the last so many months. And when we went in, the first thing we thought probably there was some issue with the dialyzer has not been properly primed, and probably that is what has gone in. So we checked with the technicians, and there were different technicians who had done. So if it was the same person, probably the error would have been same. And when we checked with they were very categorical. They have done all the steps of exactly how this thing was supposed to be done. So usual, our heparin and not heparin, sorry, hydrocortisone and Avil was given. The symptoms subtitled. The second shift came. The second shift came again. 3 or 4 patients had similar symptoms, and 1 patient became very sick. I mean, his oxygen saturation dropped to 90-80%, severe rigors. His BP crashed. We almost thought we'll lose the patient, but somehow we responded. But that really made us to sit and think at that moment that there is something wrong and we don't know what it is. Now we looked at the patients. Some were fistula, some were abscesses. None of them had features which were common. But then we started looking at when these patients had come for the previous dialysis. So all these patients were patients who were using reused dialyzer. All those patients on that day who had got new dialyzers had no problem at all. So when we looked back, we saw all these dialyzers had been reprocessed about 2 and 3 days. And these were patients who were using those dialyzers. So when we looked back, and again the people who did the reprocessing said we had done everything as per, there was no problem at all, the machine didn't say anything. And so when we looked back, we found that the disinfectant for the reprocessor was empty. And there was no sensor and there was no alarm, and it was just getting filled by the RO water without any disinfectant. And that what we found. So we had to discard all those dialyzers which were reprocessed on that day. And then so there was a problem. The step there which was not checked was they had not checked for clear the disinfectant inside. So that we introduced after that to make sure that disinfectant is there, and also to ensure every day that the.
Are you getting the disinfectant testing strips? Because they are currently not easy.
Not now.
Yeah,
at that time we had introduced. Now we are again. But
we are stuck for the same reason. And unfortunately, these reprocessing machines, we had exactly very recently the same problem. That machine, it reprocesses 2 dialyzers at a time. One side, the disinfectant filling pump was defective. So it was just not filling disinfectant in. It was, as you said, filling them with water. And once some years ago, we had a problem where we were doing manually, and where the technicians filled the tank which should have had peracetic acid with water, because it was late at night, they were feeling tired. So they filled the tank with water instead of disinfectant, and over a period of 3-4 days, like you said, all the patients on reprocessed dialysis got fractures, and they finally were able to grow cultures positive from the blood sample.
Even IV fluids might be a problem. We had 15 years back, we had a fresh packet done, and almost around 30% of the patients they were getting chills. So then we found out that the new batch that has come, it was then we saw that it was some different things only, just for veterinary use, not for human use. So then we had to tell them, and then we could return it, and everything subsided. So we have to be careful to see IV fluids also when the new batch comes.
The good part is that you can test your IV fluid endotoxin.
So taking Dr. Umapati's story further, a few years back there was an outbreak of infection in a nearby corporate hospital, and few patients became very sick, had to be shifted to the ICU. I don't remember anybody having died. But while investigating that epidemic, the nephrologists took pains to go to the stores and investigate which parasitic acid brand is being called. And it was an unbranded parasitic acid which the store had acquired because it was the cheapest, and that had hardly any parasitic acid there.
But even if you use branded, they are available in different strengths. And so in the guidelines, we have given you to look, if it's 1.8%, then the dilution is 200 is to 9,800 for dialyzer cleaning. And if it's 4.5%, then it's 65 ml in 9,600. No, the 300 ml in 9,605.
So look at the strength.
You have to look at the strength.
So that's the problem, because these are prepared by sometimes the junior most technicians are given these jobs, or sometimes not even a technician but a class 4 who is being trained, and there's a chart. So he follows the chart and he doesn't know the brand has got changed and that leads to problems.
So stores have to be controlled by nephrology.
Taking Dr. Ambekar's point that whenever you are getting outbreak, call for help. The third person may be able to find out what you are not able to find. So, any further questions? Thank you, sir.